Welcome to the deep dive. You know that feeling, right? You glance in the mirror and bam, one eye is just red. Maybe a little pink, maybe really bloodshot.
Mm-hmm.
Most of us have probably had it or seen it and just thought, oh, bit of pink eye, or maybe didn't get enough sleep.
Right. Pretty common reaction.
But it turns out that simple redness, it can be surprisingly complex. It's like a signal the body's sending about a whole bunch of things. Some totally harmless, others genuinely serious. So let's dive deep and figure out what's really going on.
Exactly. Redness in the eye, red eye, as a symptom, it's actually one of the top reasons people seek medical help for their eyes. But the story behind that redness, it varies incredibly widely.
Right.
Could be something really minor, a stray eyelash maybe, or it could be a sign of something developing fast, something that could even threaten your sight. So our goal here is to sort of equip you with the knowledge to understand the nuances, the different potential causes, the really critical clues that experts look for, and importantly, how the whole approach changes completely if it's a child with the red eye. We're going to pull back the curtain a bit.
Okay, consider this your shortcut then. Understanding what your eyes or maybe someone else's might be trying to tell you. Stick with us, because picking up on a few key signs, well, it can make a real difference in knowing when to worry and when, you can breathe easy. So let's start right at the beginning. When we say red eye, we mean the white part, the sclera, looks red or pink.
Yeah.
Fundamentally, why does that happen? What's the actual process?
Okay. It really boils down to blood vessels. The surface of your eye, that white part and the inside of your eyelids, they're covered by this thin, clear layer called the conjunctiva.
Right.
And this conjunctiva has tiny blood vessels. Normally, you barely even notice them. But when something irritates the eye or harms it, these vessels dilate. They widen up, become much more visible, and boom, the eye looks red.
Yep.
It's basically the body's inflammation response kicking in. Now, that inflammation might just be on the surface in the conjunctiva itself. That's your typical conjunctivitis or pink eye.
Mm-hmm.
But the redness can also signal inflammation deeper inside the eye. Like in the front chamber, that could be a iritis or anterior uveitis, or even in the deeper layers of the white part itself, the sclera conditions called scleritis or episcleritis.
Okay, so redness is basically the blood vessels shouting, hey, something's up. How does pain fit in? Is it always painful?
Good question. Not always, no. And whether there is pain, and really importantly, what kind of pain it is, that's a huge clue for us trying to figure out the cause. Pain usually means sensitive parts are involved.
Like what?
Like the cornea, that clear window at the front, or the iris, the colored part, or even the blood vessels themselves are, protesting. And interestingly, even something super common like dry eye syndrome, just a problem with your tear film, that can cause real irritation, like a gritty or burning feeling, and trigger redness too. And sometimes the eye actually reacts to that dryness by reflexively making too many tears. Which can seem totally backward, right?
Yeah, the body's reflexes can be weird sometimes. What other automatic reactions does the eye have?
Well, if you feel pain, or like there's something in your eye, that gritty feeling, that sensation gets picked up by a major nerve, the trigeminal nerve.
Okay.
And that immediately triggers protective reflexes. You start blinking like crazy, trying to get rid of whatever it is. And often you get a flood of tears that's called epiphora again, trying to wash the problem away.
Makes sense.
You might also notice discharge. Could be watery, could be thick and goopy like pus, or sometimes it even forms these sort of membranes or white plaques inside the eyelid. And the color, the consistency of that discharge, another key piece of the puzzle.
So just seeing redness, it really doesn't tell you much on its own. Why is getting a systematic step-by-step look so absolutely vital?
Because the range of possible causes is just enormous. I mean, it goes from something super simple, like temporary irritation from smoke, or maybe just being tired, things that'll clear up on their own.
Right.
All the way to really severe conditions that can cause permanent vision loss, or even be signs of systemic problems threatening a person's life. We're talking things like a bad infection inside the eye, a sudden spike in eye pressure, or particularly concerning in children, maybe even a sign of child abuse.
Wow.
So those very first steps, asking really careful questions, getting that initial look, they are absolutely critical to figure out quickly just how urgent things might be.
So that simple redness you might have brushed off before, it could actually be trying to tell you something much, much bigger.
Yeah.
Okay. Which brings us perfectly to the first step in solving this puzzle, gathering clues from the history.
Exactly. When someone comes in with a red eye, the absolute number one question, the most critical one right off the bat, has to be, did anything get in your eye? And immediately after, what was it?
Why is that specific question so crucial right at the start?
Because if the answer is yes, and it was a chemical, especially something nasty like drain cleaner or oven cleaner, those are strong alkalis that requires immediate, relentless irrigation, like right now.
Perfect.
You have to wash that eye out with tons of water right that second. You don't stop to check vision. You don't wait for sterile saline from a kit. You grab any clean water you can find, tap water, anything, and start flushing. Every single minute counts. Those things can cause severe damage, permanent vision loss, incredibly fast.
Okay, rule out chemical burn first, urgently. Got it. Once that's clear, how does digging into the details like the pain help you narrow things down?
The pain characteristics. They're major differentiators. Think of it like this. Different kinds of pain point to different parts of the eye. Someone says their eye itches. That often points to surface stuff, like blepharitis, inflammation of the eyelids, or common conjunctivitis, or maybe dry eye, a burning sensation, could be those too, but also things affecting the very front surface, like a little growth called a pinguecula or episcleritis, or again, dry spots.
Okay, what if it feels like something's in the eye?
That foreign body sensation, that almost always means the cornea, the clear window is irritated, maybe a scratch and abrasion, maybe an ulcer starting, or just inflammation there, keratitis.
And sharp pain.
Sharp pain usually signals a problem with those sensitive structures right at the front, the cornea, the iris, or maybe a sudden pressure spike like an acute angle closure glaucoma.
What about a dull ache?
A dull aching pain is a bit less specific.
Okay.
It could be elevated eye pressure, yeah, but it can also be referred pain coming from somewhere else, like a sinus infection, a migraine, or especially in older folks, it could be temporal arteritis, inflammation in the arteries near the temples, which is actually very serious and needs urgent attention.
Wow, okay. What about the redness itself? Does the way the eye looks red give you clues?
Yes, absolutely. The pattern, the color, it all matters. Most red eyes are just those tiny conjunctival vessels getting swollen and red, making the whole white part look pinkish.
Right.
But sometimes you see actual blood, like free blood. If it's a bright red patch, usually just in one section, sitting under the conjunctiva, that's a subconjunctival hemorrhage. If it just appeared out of nowhere, it's usually painless, looks worse than it is. But if it happened after getting hit, then the pain tells you there might be an injury underneath.
Okay.
A more worrying sign is if you see a layer of blood actually inside the eye, settled at the bottom of the front chamber, behind the cornea. That's called a hyphema, usually caused by trauma, typically painful, and it blurs vision because the blood physically blocks the light coming in.
Gotcha. What other things might someone report, like subjective feelings?
Lid swelling can happen. Tearing, like we mentioned, very common. The discharge is crucial. If it's thick, yellowish or greenish, really purulent, strong pointer towards bacterial conjunctivitis. Light sensitivity photophobia, that's a really significant sign. It often suggests something more serious inside the eye is inflamed, like iritis, or cornea problems like keratitis, or that dangerous pressure spike in angle closure glaucoma.
What up?
Sometimes the conjunctiva itself swells up and looks like a watery blister that's called chemosis, really typical of allergic reactions. And occasionally you might see whitish or yellowish stuff forming on the inside of the eyelids, like little plaques. Those are called pseudomembranes, and they can point towards specific infections like adenovirus or potentially severe systemic reactions like Stevens-Johnson syndrome.
And asking about risk factors sounds absolutely critical for getting a handle on things. What are the big ones you look for?
Oh, this is where you really start to zero in and spot the high-risk situations. The single biggest risk factor for serious red eye problems, hands down, is contact lens use.
Really? That
Yeah.
big a deal?
Huge. Contact lenses fundamentally change the eye's surface environment. They reduce oxygen to the cornea, and they make it much, much more vulnerable to bacterial infections and potentially blinding corneal ulcers. You need to ask everything. What kind of lenses? How long have they worn them? How do they clean them? Do they sleep in them? It's such a major risk that any contact lens wearer who comes in with a red eye, even if it looks pretty mild, needs to be seen by an eye specialist right away, urgently. The risk of a rapidly worsening sight-destroying infection is just too high to wait.
Wow. Okay, so just wearing contacts bumps a red eye way up the urgency list?
Yes.
See a specialist now territory?
Absolutely. Without question. Other key risk factors. Their past medical history. Have they had eye problems or eye surgery before? Do they have systemic conditions? Things like giant cell arteritis, which we mentioned can cause eye issues, or autoimmune diseases like juvenile idiopathic arthritis, JIA, sarcoid, inflammatory bowel disease. All of those can manifest in the eyes. Known allergies. What medications are they taking? And of course, the details about this episode. Did it start suddenly? Has their vision changed at all? Have they been sick recently? Was there any kind of trauma, even minor?
It really is like being a detective, gathering all the evidence before you even lay eyes on the eye itself. Just by listening carefully, you can already start building a list of suspects for what's causing that redness. Okay, so you've got the story, the history, the initial clues. Now it's time to move from listening to actually looking, the physical examination. What's the absolute first thing you check, and why is it so vital?
The most vital sign, number one, always, is visual acuity. How well can the person actually see?
Why first?
Because it gives you a baseline immediately. It tells you how much the vision is currently affected, and it's actually a strong predictor of the final outcome, how well they'll recover. We use standard charts like the Snellen chart with letters, or a near card called the Rosenbaum.
What about kids who can't read letters?
Good point. For young kids, we use things like the Allen chart, which has simple shapes or pictures. If someone's vision is really poor, we check more qualitatively. Can they count fingers held up in front of them? Can they see you wave your hand? Can they just perceive light at all?
Okay.
There's also a quick test using a pinhole occluder. If looking through a tiny pinhole makes their vision significantly clearer, it suggests the main problem is just needing glasses or refractive error, rather than something pathological causing the blur.
Got it. After vision, you start looking at the eye structures themselves.
Yep. A systematic external exam comes next. First, just look at the eyes, their position. Is one eye bulging forward compared to the other? That could suggest swelling or blood collecting behind the eye, pushing it out.
Mm-hmm.
Then, crucial steps like averting the eyelids, gently flipping the upper lid inside out. You'd be surprised what can get stuck under there, causing irritation. Then we look closely at the pupils.
What about them?
Their size, their shape, how they react to light. We might do what's called a swinging flashlight test, moving a light back and forth between the eyes. This checks for something called a relative afferent pupillary defect, or RAPD.
Okay, what's that?
It means the signal isn't getting back properly from the retina to the brain on one side. It points to potentially serious damage to the optic nerve or retina itself. Also, an irregularly shaped pupil isn't normal. It could be from trauma or maybe from previous bad inflammation where the iris got stuck to the lens or cornea.
How do you check the pressure inside the eye? That sounds tricky.
That's measuring the intraocular pressure, the IOP. Normal pressure is usually somewhere between 10 and 20 millimeters of mercury, mmHg. Pressure over 20 is getting high, needs looking into. Pressure over 30 is very high and needs rapid treatment to prevent damage to the optic nerve, that's the cable carrying vision to the brain.
How's it measured?
We use special instruments called tonometers. There are different types. And you're right, getting an accurate IOP reading in little kids can be really tough. Often needs specialist equipment, sometimes even sedation or examination under anesthesia.
The slit lamp seems like the real powerhouse tool here.
Yeah.
What exactly does that let you see?
Oh, the slit lamp is indispensable. It's essentially a microscope designed specifically for looking at the eye. It gives you this highly magnified three-dimensional view, letting you see incredibly fine details.
Like that.
You can examine the eyelids and eyelashes meticulously, the conjunctiva and the sclera. And crucially, the cornea, you can see tiny scratches, ulcers, foreign bodies stuck in it, and even judge how deep they are using the narrow slit beam of light. It lets you look into the anterior chamber, that space right behind the cornea.
What are you looking for in there?
You can actually see tiny inflammatory cells floating around. Looks almost like dust motes in a sunbeam. Or a general haziness called flare. Those are key signs of inflammation inside the eye, like hydritis. You can also clearly see blood layered at the bottom, a hyphema, or even pus, which is called a hypopyon. Then you can examine the iris itself and the lens behind it.
And you look at the back of the eye, too, the retina.
Yes, the fundoscopic exam. Sometimes we can get a decent view just looking through the pupil, but often we use dilating drops to widen the pupil for a better look at the retina and optic nerve. We have to be careful, though. We would not dilate if we suspect acute angle closure glaucoma, because that could make the pressure spike even worse.
Mm-hmm.
But sometimes you just can't see the back. The view might be blocked by problems up front, like a cloudy cornea, that hyphema filling the front, a very small pupil, a dense cataract, or maybe blood in the vitreous jelly that fills the main part of the eyeball.
It really is incredible, like having microscopic vision for the eye, seeing all those hidden details. Okay, so you've done the history of the exam, used the slit lamp. What other tools help you really nail the diagnosis?
Fluorescein staining is a classic, very useful tool. It's a special yellow-orange dye we put in the eye as a drop or on a strip. Then, under cobalt blue light, any place where the surface layer of the cornea, the epithelium, is damaged or missing glows bright green.
Ah, so it highlights scratches.
Exactly. Scratches, abrasions, ulcers, they light right up. It can even show specific patterns, like a branching tree-like pattern called a dendrite is almost diagnostic for a herpes simplex virus infection on the cornea. We can also use fluorescein for something called a Seidel's test.
What's that?
You put a generous drop of fluorescein on the eye and watch carefully. If there's a tiny puncture wound leaking fluid from inside the eye, you'll see the clear fluid washing away the orange dye, creating a little clear stream. It tells you the globe isn't intact.
And sometimes imaging, like scans, are needed.
Yes, definitely. Especially if there's been trauma or you suspect something got into the eye, a foreign body. CT scans, especially with fine cuts, are great for finding foreign bodies, even ones like wood or glass that don't show up well on regular x-rays. They also show bone damage around the eye really well.
What about ultrasound?
Ultrasound can actually be even more sensitive for detecting small foreign bodies inside the eyeball itself. MRI gives beautiful pictures of the soft tissues, the muscles and nerves behind the eye in the orbit. But big caution, MRI is absolutely contraindicated if there's any chance of a metallic foreign body being in there. The powerful magnet could pull on it and cause devastating damage.
So it's really about putting all these pieces together, the story, the exam, the tests, to arrive at the diagnosis.
Exactly right. It's often an iterative process. You gather info, form a hypothesis, use a test to check it. Sometimes even a simple step is diagnostic, like putting in a drop of topical anesthetic. If the pain vanishes completely, tells you the pain source is right on the corneal surface. If it only helps a little, maybe conjunctiva. If the pain is still bad, it's likely deeper inside the eye.
Okay, now for the really critical part, spotting those red flags. The signs that shout, this is serious, act fast. What are the absolute high alert indicators we need to know?
These are the things you just cannot afford to miss because they signal conditions that can steal vision quickly and permanently. There's one sign, sometimes called the ominous sign, and it's vital for anyone who wears contact lenses to know.
Okay, what is it?
It's a white spot on the cornea in a contact lens wearer, especially if the rest of the eye, the conjunctiva, is inflamed. That white spot is highly suspicious for a bacterial corneal ulcer. These things can literally eat through the cornea and cause blindness in a matter of days, sometimes even hours. This is precisely why we keep stressing that all contact lens wearers with any red eye, even if it seems minor, must get an immediate evaluation by an eye specialist. Waiting even a day could be the difference between saving sight and losing it.
That is a stark, crucial warning. Knowing that specific sign, white spot, contact lens could genuinely save someone's vision by getting them help immediately.
It's probably one of the most critical takeaways, yes. And speaking of critical differences, evaluating and managing red eye is profoundly different when the patient is a child. Kids are absolutely not just small adults when it comes to their eyes.
What are the main challenges or differences when you're dealing with a child's red eye?
Well, first off, cooperation. Try getting an infant or a scared toddler to sit still for a detailed slit lamp exam. It takes patience, different techniques. Measuring vision accurately in kids who can't read letters requires special charts, like those shapes we mentioned. And getting that eye pressure, the IOP, measured accurately. That's particularly tricky in kids, often needing an ophthalmologist with specific tools, maybe even sedation.
Okay, and what causes of red eye are more unique to kids or more worrying in that age group?
There are several really important ones. In newborns, infections picked up during birth are a big concern. Things like herpes, chlamydia, which might not show up for a week or two, and critically, Neisseria gonorrhea. Gonococcal eye infection in a newborn is a true ophthalmic emergency. It needs immediate, specific IV antibiotics to prevent perforation and blindness.
That sounds terrifying.
It is. Also, simple corneal abrasions are pretty common in infants, maybe from a fingernail scratch.
Yeah.
They can cause intense, inconsolable crying, and that might be the only symptom you get.
Oh.
Then there are the links to systemic diseases in kids. Kawasaki disease, a serious inflammatory condition, often causes very noticeable conjunctival inflammation, and juvenile idiopathic arthritis, JIA, this is unique. The associated iritis, the inflammation inside the eye that's often completely asymptomatic in kids.
No symptoms at all?
Often none, no pain, I might not even look red. But meanwhile, the silent inflammation is causing potentially permanent damage inside. That's why children diagnosed with JIA must have routine screening eye exams by a specialist, even if their eyes seem perfectly fine. Waiting for symptoms is often too late.
That's crucial.
Also, simple conjunctivitis in very young infants, like under 3 months, can sometimes be linked to ear infections or respiratory issues.
And there was a particularly serious potential cause mentioned earlier, related to children.
Yes, and it's a difficult but critical point we have to raise. Child abuse is explicitly listed as a potential, even life-threatening cause of red eye in children.
How so?
It might not be obvious trauma. It could include someone deliberately putting harmful substances into a child's eye, a form of medical child abuse, or Munchausen by proxy. Also, that subconjunctival hemorrhage, the blood patch. In a young child, especially if it's a very dramatic 360-degree ring of blood all around the eye, that needs careful thought. While intense coughing, like with whooping cough, can cause it, it should also trigger investigation for a bleeding disorder or, tragically, non-accidental trauma, potentially related to suffocation. So a red eye in a child can sometimes be a vital clue, a red flag, for much broader, very serious non-accidental issues.
That is incredibly sobering. It really drives home how what seems like a simple red eye can be profoundly different and sometimes vastly more serious in a child. Vigilance for those specific clues, both in the eye and the bigger picture, is just paramount.
Precisely. Understanding those age-specific risks and presentations is absolutely fundamental to good care. So, okay, the evaluation's done. You have a diagnosis, or at least a strong working diagnosis. What happens next? Management, obviously, is tailored to the specific cause, but there are some key principles that apply across the board.
Let's circle back to that chemical exposure emergency. You said immediate irrigation. How long and with what again?
Immediate and copious irrigation. Non-stop flushing. The goal is to dilute and wash away that chemical ASB. And the best thing to use right away is any clean water available, tap water, bottled water, whatever's handy. Don't waste precious time hunting for sterile saline.
Right.
Get the eye under a gentle stream of water for at least 15-20 minutes. Alkalis, like drain cleaners, penetrate deeper and cause more damage than acids, so they need even longer flushing, maybe 30 minutes or more. You keep going until the pH of the tears returns to neutral, which can be checked with pH paper. And if there were any solid chemical particles, you gently sweep those out before starting the flush.
How do you manage the pain? Some of these conditions sound incredibly painful.
Pain relief is definitely important, both for the patient's comfort and just to allow a proper examination. Those topical anesthetic drops are fantastic during the exam. They numb the surface, stop the intense pain and eyelid squeezing, letting the doctor actually see what's going on.
Mm-hmm.
And like we said, the response to the drop can help figure out where the pain's coming from. And this is absolutely critical, topical anesthetic drops are never given to patients to take home.
Wow.
Because they can mask worsening symptoms. If an infection is getting worse, the patient won't feel it as much. Plus, the anesthetic itself is actually toxic to the corneal surface with repeated use. It can delay healing and even cause more damage. So for severe pain that persists, we'd use oral pain meds or sometimes even IV medication if needed.
What about antibiotics? Does every red eye need antibiotic drops?
No, definitely not. While we certainly use topical antibiotics for confirmed bacterial conjunctivitis or, very importantly, for bacterial keratitis, especially with contact lenses, many common red eyes are caused by viruses or allergies or just irritation. Antibiotics won't touch those. Because telling viral from bacterial pink eye can be tricky early on, a common strategy now is the delayed treatment approach.
How does that work?
We educate the patient, explain that many cases get better on their own in a few days. We might give them a prescription for antibiotic drops, but advise them not to fill it or start using it unless their symptoms haven't improved or have actually worsened after about 72 hours.
Ah, interesting.
Yeah, it helps cut down on unnecessary antibiotic use, which is important for combating resistance. Of course, for severe infections like bacterial keratitis or infections inside the eye, we use specific, often stronger antibiotics right away, sometimes IV. And herpes ulcers on the cornea need urgent antiviral treatment, not antibiotics.
What are some of the really critical interventions for the most severe problems?
Okay, for acute angle closure glaucoma, that sudden pressure spike, we need rapid treatment to lower the pressure using multiple types of eye drops, sometimes pills too. Severe infections like orbital cellulitis infection behind the eye or endophthalmitis infection inside the eye usually mean immediate hospitalization and strong IV antibiotics. And in a true emergency like orbital compartment syndrome, where pressure behind the eye is crushing the optic nerve, An emergency surgical procedure called a lateral canthotomy might be needed to literally cut the corner of the eyelid open and release the pressure to save vision.
Wow, that's intense. What about really common things like a simple corneal abrasion? Any surprises in how those are treated now?
Yes, actually. This is a good example of how guidelines evolve. For a simple corneal abrasion, just a scratch on the surface, pain relief is key, and making sure any foreign body is out. But based on good evidence now, some things people used to do routinely are often not recommended anymore.
Like what?
For simple superficial abrasions, routine antibiotic drops are generally not needed. Using drops to dilate the pupil, cycloplegics, also not routinely necessary just for pain relief. And crucially, patching the eye is not required and may actually be harmful.
No patching. I thought that was standard.
Used to be. But patches can create a warm, moist environment where bacteria like to grow. They stop oxygen from the air getting to the cornea, which it needs to heal. And they make it impossible to check the eye easily or put in any lubricating drops. So no patch for simple scratches. Now, if a metal foreign body left a rust stain, that does need to be removed, but usually by a specialist within a few days, not necessarily as an emergency.
So less is more sometimes, and avoiding things like patching is actually vital. Okay, so after the initial treatment, what usually happens?
Most people with straightforward issues are discharged home with instructions, maybe lubricating drops, advice on symptoms, and told to follow up in 1 or 2 days. That follow-up is really important to make sure things are heading in the right direction.
And if they're not?
If they're not getting better, or if the diagnosis is more complex from the start, like uveitis, scleritis, significant trauma, then referral to an ophthalmologist is definitely needed. Sometimes admission to the hospital is necessary, maybe for a large hyphema, or if there are serious systemic health concerns tied to the eye problem. And just to reiterate, no patching for hyphemas or abrasions, but wearing a rigid protective shield, especially at night, is a good idea if you have a hyphema, just to prevent accidental bumps.
This has been incredibly eye-opening.
Yeah.
Slightly intended. Thank you so much for walking us through the surprising complexity behind something as common as a red eye.
My pleasure. It really is a perfect example of how one simple-seeming symptom can have so many vastly different stories behind it.
I hope this deep dive gave all of you listening some really valuable insights, from recognizing those critical warning signs, like that ominous white spot with contact lenses, to understanding why screening is so vital for kids with JIA, even when their eyes look perfectly fine. Knowing about the potential difficult links to child abuse, and even those counterintuitive treatment details, like why patching a simple scratch is actually not the way to go anymore.
Absolutely. And, thinking about how much careful, detailed investigation is needed just to truly understand what a red eye might mean, it kind of makes you wonder, doesn't it? What other seemingly simple symptoms our bodies might present? How many of them also hold surprising layers of complexity just waiting to be carefully unpacked?
That is definitely something to think about. Until next time on The Deep Dive.